We're using the pars jig here. Through this minimally invasive incision, we can still move proximally. We make sure that it's parallel with the tendon itself, which is under some modest tension, and then the pin can be inserted. This ensures an excellent proximal locking fixation. Care is taken as this is passed, but you can see how this can easily be inserted, and the guide itself then ensures that pin position is accurate and that soft tissue fixation is optimal. This is just another level of sophistication if you feel that the more distal Achilles tendon is not sufficiently robust when you put in your modified Kessler suture. We're crossing over here as the system allows this to lock easily, but it adds very little in terms of time to the overall procedure. And if the jig's correctly positioned here, parallel with the tendon itself, there should be minimal risk of sural nerve irritation or injury. It's always good to have an experienced team with you. Simplifies it enormously. And with this technique, the risks of any complication can be minimized. We can now gently withdraw the pars jig itself, and you can see the sutures passing easily through the soft tissues and then out. And it's all enclosed within the paratenon to minimize any risk of scarring or irritation. What we're doing now is we're just ensuring that the calcaneal insertion is deep within the calcaneus itself. It's parallel to the fibre, so it can run comfortably within the Achilles substance itself. We make a nick to bone approximately 15 millimeters apart, and it's just really a stab incision that allows us to prepare the bone itself for the swivel lock fixation. We will drill at this stage, perpendicular. Excellent. And then we repeat the process. Once we're happy with the fixation, we can tap, and usually find, except in the very elderly patients and occasional cadavers, that tapping is essential. We just take it to an appropriate depth. The beauty of the swivel lock, once it is inserted, is it doesn't add any extra tension to the Achilles itself. The heel has been prepared, and this doesn't need to be screened. You can palpate your landmarks, and it's just as the tendon blends with the periosteum at the back of the calcaneum. We then take the banana lasso. What we found is that the distal stump is evident here, and it's very easy then to pass the banana lasso through the substance of the Achilles. Once you can see it coming out and you're happy that it's positioned, we can then simply feed this through, and it's easy to retrieve through the loop itself. We'll retrieve all three sutures at the same time, gently pulling them through the banana lasso, and as it comes through, that's easy, and we can gently just take all the structural tissues back through. To repeat the process, again identifying the distal Achilles so that you're comfortable that you're in the substance of the Achilles itself, advancing the loop, allowing the loop to open, sutures then grasped and pulled back through, and once it's all slipped through, simply retrieve the banana lasso, gently bring the sutures distally. It is possible to take the suture material just slightly within the distal portion of the Achilles itself, so that it's within the substance so the points actually match directly, and that would be a worthwhile additional step. We're then establishing the correct musculotendinous length, which should match the equinus of the unaffected side. Once we're happy that this has been approximated, we know there's not going to be any suture irritation or slippage or mechanical weakness at that site, and we can close the paratenon comfortably once more, just over the remaining suture. So we can close the paratenon there, and we effectively have a normal looking repaired Achilles tendon. The next stage is to keep the position of the foot in the appropriate equinus and load the swivel lock anchor. You want all three sutures to be equally tensioned. When you're inserting, you make a modest allowance for the depth of the anchor itself before this is fixed. Usually you can push this into the pre-prepared hole, but a gentle tap with a mallet can facilitate. Again, we're checking that we're not added excessive tension, that the resting position when it's unsupported. If it's unsupported, we should find that it rests at its natural length. You then know that you can safely advance by holding the blade with your left hand, and clockwise with your right, you can advance, and there's no further tension added to the construct. The idea is not to over-tension the repair. This extra anchoring suture can then be removed. Swivel lock taken, and then the fibre wire scissors allow us to cut this as flush as we can to the surface itself. We then repeat the process. The length is set. It's easier to insert the second anchor. That's great. Again, all the tension's even. This is slipping nice and easily. We find our entry point. Just a gentle tap. Check it once more Just to make sure you're happy with the repair and approximation, advance gently, retrieve the anchor suture once more. So we take the fibre wire scissors or scalpel blade and minimise the remaining suture. It's possible to steady strip the repair at the end. However, if we have a final look at a repair, sometimes there's some soft tissue strands that you want to approximate around the site of rupture, and you can use a small vicryl suture. But otherwise, the paratenon can be closed directly. And as this comes down, you can see how smoothly the tendon moves in between. We close the skin with an absorbable suture, and we have restored normal anatomy. But not only that, it will be sufficiently strong to allow early mobilization without attenuation and loss of power during our accelerated rehabilitation program.